in your just outpatient clinic setting, and how these things can present unique challenges and also some strategies to be successful with these type of individuals. So first, when we just think about personality and what that really means, it's really an enduring pattern of perceiving, relating to, and thinking about the environment and oneself, which is a really sort of broad definition. It's the result of genetics and temperament and environment. And really our personality is made up of coping skills and defense mechanisms that help us adapt and change to stress, which is really required for functioning. So we all have some really positive coping skills and positive defense mechanisms. And when under stress, anyone can really look like they have a personality disorder, because our defense mechanisms become more primitive when we don't have all of our executive functioning on board to manage stress. So when you think about a disorder in terms of a personality disorder, you can go to the next slide. This is just a general definition of a personality disorder. So it's an enduring pattern of inner experience and behavior that deviates markedly from expectations of an individual's culture. So this presents in a lot of different ways. In terms of cognition, this is the way people perceive and interpret themselves and others and the events around them. In terms of emotion, things are unexpected in terms of people's range of emotion, the intensity and lability or appropriateness of an emotional response to an event. It really affects person's inability to function on an interpersonal level, and people with personality disorders often have poor impulse control because they don't have the coping skills to manage their stress level. So things become externalized. So this is often inflexible, pervasive across a broad range of personal and social contexts. So we don't classically diagnose personality disorders when somebody is in the hospital, either in the psychiatric hospital or on a medical floor, because again, they're going through an enormous amount of stress. And in that situation, someone can look like perhaps they have a personality disorder, but it really presents across all contexts, whether they're in a stressful situation or not. So if someone is in the throes of a mood disorder, say they're manic or severely depressed, or struggling with a substance abuse problem, again, it can really look like they have a personality disorder, but we make this diagnosis over the long term, looking at different aspects of a person's life and not just in an acute crisis. It starts in adolescence or early adulthood, and is, again, not due to another medical disorder or substance problem. So the DSM-5 kind of mixed things up a little bit. I think that the 5-axis system that we used to have, where axis 2 was a personality disorder or cognitive disorder, and axis 1 was other major mental health conditions, has changed. And so with the DSM-5, they've done away with the axis system, and everything is sort of on the same axis. And the thought is it sort of removes the artificial distinction between personality disorders and other conditions. And so you're just going to see that, and probably have seen that ongoing because of this change. Although habits die hard, so we still see the axial system. And some insurance companies, at least on our inpatient unit, still require that. And so it's just kind of, things are evolving in that area. So it's really divided. This hasn't changed from the DSM-4, but personality disorders are divided into 3 clusters. So cluster A are people that present with odd or eccentric behaviors and interaction styles. Cluster B are dramatic, emotional, or erratic. And cluster C is anxious or fearful. So we'll just kind of go through these one by one, spending the most time on cluster B, because really, as you all know, that's what we see. And what causes the most difficulty in the healthcare setting is the dramatic, emotional, and erratic personality disorders, and take a large number of resources and energy to manage. So we'll talk about all of those. And we'll start with paranoid personality disorder. You know, before I start talking about this, I just want to mention that these are very difficult to manage. Personality disorders in and of themselves are very difficult and really can affect your ability to deliver good care. And so I just want to acknowledge that and say that, you know, those of us who deal with people with these conditions all the time make mistakes all the time. None of us are really all that good at managing it. I think we just kind of learn from our mistakes and do the best that we can. So paranoid personality disorder, these are individuals who have a pervasive sense of distrust, very suspicious, preoccupied with other people's untrustworthiness, reluctant to confide in you. They read threats into everything, bear grudges, very sensitive to attack, suspicious of infidelity in partners. When you think about a differential diagnosis, it can look somewhat like delusional disorder or schizophrenia, but the pervasive nature of it and the fact that the person isn't necessarily psychotic is what differentiates it. So these are, I just read this book called A Man Called Uwe, which is a very popular book right now, and I think it's also a movie. And the man in this book, I think, classically represents paranoid personality disorder. But these are individuals where, you know, you just have to tolerate their level of suspiciousness, kind of roll with the resistance. So they're trying not to get too defensive, but just give thorough explanations, respect their privacy, because there's things they're not going to tell you, or they're going to get suspicious if you want to know too much. And just allow them to express those doubts about care issues. And it just takes time, you know, building trust over time. This is the type of patient that if you have one provider that can follow them and not use physician extenders, I think you can be more effective. So next we have schizoid personality disorder. These individuals are very detached and don't show a lot of emotion. Often they live alone, never been married, maybe outside of their family, don't have any friendships, maybe not have major depression, but really don't experience joy from things. They're really indifferent to feedback, can come across as pretty cold. So when you have an individual like this, they're going to have a lot of anxiety in a condition where they're forced to be around a lot of other people. Like, for example, a hospital admission is going to be very disorienting for a person like this. So again, it's over time building trust, maybe care through a single physician if possible, and then really just going for the facts, because you're not going to be able to connect with this type of individual over feelings, because that is not their area of strength. It's going to have to be just very fact-based with people with schizoid personality disorder. Schizotypal personality disorder. Also, again, all of these in cluster A, there's a lot of isolation and social anxiety. What makes schizotypal personality disorder different is that these individuals are very eccentric, have a lot of cognitive distortion that at some times can seem on the border of psychosis, because they have a lot of odd beliefs. They might have unusual perceptions or odd thinking, maybe be very suspicious, odd in their appearance, odd in their behavior. And, you know, it just comes to mind, I have this individual in my practice who, you know, a man in his 60s, he lives alone in a basement apartment, very few friends or social interactions. His apartment is full of snakes and cats, and he spends most of his day chanting. He comes into the clinic hours before his appointment and sits in the clinic, and he dresses in all black in a black trench coat, even in the summer. He has these very intricate dreadlocks that are very odd appearing, woven into his hair. And again, he's in his 60s. So this is classic for him. I mean, he meets sort of all these criteria. And what we do and what is recommended that I think is effective is just to tolerate that odd interaction. Setting boundaries, of course. You know, you don't want other patients to feel uncomfortable. You don't want to feel uncomfortable yourself. But sometimes these patients need an alternative evaluation and an alternative therapy to be discussed, to feel like they're getting their needs met. And again, being followed by one physician over time can be helpful. But I think it's just rolling with and recognizing that their need to present in this way mitigates some of their anxiety about just being out in the world. So we'll talk about cluster B. These are well known to all of you, I'm sure: antisocial, borderline, histrionic, and narcissistic. There's a lot of comorbidities with these illnesses. So a lot of mood symptoms, anxiety and PTSD, eating disorders, dissociative symptoms, and somatoform disorders, as well as substance abuse. And they're very, very common in clinic. And again, as I said, take up an enormous amount of resources. So this cluster of patients, I want to just say a little bit about countertransference. So it's a fancy term in psychiatry, but really what it means is it's the ability of the patient to almost imprint their internal state onto you. So if you ever have an encounter with a patient and you leave and you feel completely disorganized, completely angry, completely out of sorts, just not yourself, and this isn't you typically, I think it's a really great opportunity to just step back and say, what just happened? And then to realize, whoa, maybe that's how that person feels all the time. Because this cluster B personality disorder is very good at sort of putting their internal chaos onto others. And so with all of these disorders, we'll talk about them specifically, I really just try to like hold the space and try to organize myself and be aware of my own feelings of chaos, because if you're in this kind of situation, it can make it really difficult to think and to organize yourself. But again, just being aware of that and sort of putting it back on them and understanding where your emotions are coming from can really help you be more effective. So antisocial personality disorder, these are individuals who disregard and violate the rights of others. There's a lot of unlawful behavior often involved in the justice system. They can be deceitful, impulsive, irritable, just really irresponsible, and not have a lot of regard for safety. So strategy here is just to be careful, you know, to make sure that you're safe, that you feel comfortable in the situation, that you've got good boundaries in place. Just having dishonest reporting of symptoms goes along with the territory. So it's important just to rely on objective findings and take the things that you hear reported with a bit of a grain of salt, and just rely on objective findings, because there's a high risk of malingering. I mean, these are individuals who will come with the note excusing them from work sort of already written and just ask you to sign it, or I mean, there's a whole host of things. They might threaten to sue you. So I think it's just important to document thoroughly. Often what I'll see with some of my antisocial folks is that they are very, very nice to me, very, very charming to me, but the reports that I get are that they are kind of a jerk to the nurse, or disruptive and rude at the pharmacy, or it's like a splitting of, okay, you're the person who can get me the meds that I need or the note that I need, but these other people don't matter. And so if you see that, or your experience with an individual in your office is very different from their interaction with maybe the ancillary staff, it's just a red flag that maybe this is something that's going on. So that's antisocial. Borderline, I think, is probably what most people have a lot of experience with. I think of borderline personality disorder in terms of instability. So these are people that there's just a lot of chaos, instability in their environment, instability in their sense of self, instability in their mood. So their mood is all over the place. They are terrified of being abandoned. So they will go to great lengths to avoid that. They either love you or hate you. And at times it's on the border of narcissism and psychosis. And so they can have transient paranoia, sort of micro psychotic episodes. And so with these individuals, and at the end, we'll talk a little bit more about how to manage that at the very end of my presentation, but it's really about consistency. And again, they can make you feel very disorganized, you feel very unstable. So you have to kind of get yourself set and set limits. So about maybe what you're going to talk about in that visit today and what's going to go in the parking lot for the next visit. They tend to do better with, you know, regular, consistent, scheduled visits. And then you have the opportunity to say, you know what, I know you're really worried about your toe that goes numb, and right now I'm really worried about your cutting. So let's talk about that, and we'll put your toe on for next visit, or however it is, so that you can just manage one thing at a time. Really, a stable relationship with one physician is recommended, because these patients are very good at splitting. So they can pit one person against the other, or, again, value one and devalue the other, which makes it very difficult to provide effective care. And I think it's okay to tolerate all that affect that's coming at you, but you have to feel safe and you have to feel comfortable. We have a number of patients that we have phone contracts with in the office. So, we'll say, okay, we will call you back no more than once a day. So if you're going to leave, 16 messages, we'll call you back once. Or, maybe we won't even listen to all of those messages. But just having set limits and then following through with them in a gentle way can be really organizing for a person who is feeling really disorganized. Histrionic personality disorder. These are folks that have a lot of emotion and attention seeking. They really want to be the center of attention. They can be seductive, have shallow emotions, impressionistic speech, which means they just really are trying to leave an impression, but there's very short on the details. So this is the individual who grabs the picture of your granddaughter in your office and is like, oh my gosh, she's so beautiful, I can't believe how gorgeous. And you've just really just met them, and it feels a little too close for comfort, but they have this kind of pseudo intimacy that can make you uncomfortable. These are the individuals who have one individual who I have to set limits on their behavior in the waiting room, because they'll often try to start group therapy in the waiting room, just wanting to be the center of attention and wanting kind of to be noticed by everyone in the waiting room in a way that's really not appropriate. So I think it's helpful to really seek details, because again, if you have this broad speech that's short on details, you're going to want to hone in and narrow in on the specifics, just knowing that a lot of the complaints may be exaggerated. So again, relying on objective findings. These are individuals that are often really good placebo responders, and just kind of confronting the behavior gently so that you can be more effective. Narcissistic personality disorder is a difficult one to manage. These people are legends in their own mind. They feel very grandiose. They want the best of everything. And they just feel very special and entitled. So they don't have a lot of empathy for others. They will kind of step over people to get their needs met. And they just, again, want to feel like they're the most important person in the room, no matter what room they're in. So these individuals really like to challenge you. And so you can kind of flip that by, as much as appropriate, engaging them in the decision making, as long as it's safe to do so. And then really kind of use that sense of entitlement to get them motivated to take care of themselves. So maybe you want to give them even assignments to do research on the best exercise for their condition, or, just letting them know that they really do deserve to take care of themselves. And so this is something you can do to be the best, or kind of arranging your conversation to support their personality structure. And then cluster C, avoidant, dependent, and obsessive compulsive. These have a lot of also comorbidities, especially with anxiety disorders. So avoidant personality disorder, these are individuals, this can be considered on the spectrum with social phobia, that it's so severe and pervasive that it really affects every area of their life. Just extremely anxious in social situations, extremely low self-esteem, really difficulty, and will go to great lengths to avoid being in any kind of social situation. And these are all individuals are the ones who shop in the middle of the night at Walmart because they just cannot tolerate being around other people. They're very self-critical and don't want to take risks. So with a person like this, they typically physically will seem small in your office. I mean, they, are folding in on themselves because the ability to even make it to your office is very, very difficult. So it takes time to just allow them to warm up. They're not going to be able to handle a very confrontational style of communication. So you're going to kind of have to go through the back door with your conversations, and not hit subjects directly on, because they will take it as critical and just shut down even further. And you're just going to have to be more active in the interview because it's just very difficult for them to even be around other people. People with dependent personality disorder they really just haven't differentiated. They can't, and it's very difficult for them to tolerate being by themselves. They need a lot of advice. They're going to be very deferential because they really want you to like them. They're not going to disagree with you, but you might come up with a plan and then they don't follow through with it because they need so much support and don't have a lot of initiative. So these people, they seek new relationships all the time, again, really afraid of being alone. These are the individuals that you just can't get them out of your office. Like, you're standing up, you're trying to get them to the door, but they have one more question or one more concern, and I think the approach here is just to recognize the dependency, but also to set limits. Again, this might be an individual where you set a regular appointment time, so you can say, our time is up now, but I will see you again next week or in 2 weeks, and we'll further discuss all of your concerns. And then a lot of the others we talked about, needing one provider to follow them over time, but really with someone with dependent personality disorder, this can be very exhausting. And I think what you want to do is use extenders, use nurses, use groups, so that the dependency doesn't focus in or hone in on one individual, but that it's diffused across a group of people. And I think that can be more effective and help the person with this disorder as well, so they've got multiple resources instead of just one person to cling on to. Obsessive compulsive personality disorder, these are individuals who are really preoccupied with order and control, very detail oriented, often workaholics and overly conscientious. It may take them a very, very long time to get things done because it has to be perfect, and they go back and they check It's different from obsessive compulsive disorder, but has some similarities. They don't want to delegate. They're very frugal and rigid and stubborn. These are individuals who are just going to want to see everything in line, set up, no unknowns. They're going to do tons of internet searches, bring in articles. And so I think it's just rolling with that resistance and rolling with that need, just appreciating that that's what they need for support. And allowing, when it's possible, to kind of let them have some control over their treatment options, and using their ability to research to help support them. So this is just a list of guidelines for your resources if you're interested in further information on personality disorders. So when we talk about comorbidities with borderline personality disorder, especially, when you look at this, any mood disorder, it's like 96%. So people with borderline personality disorder Very difficult. They're going to be on a lot of medications, and you do want to treat the comorbidities. You want to treat the mood disorder and try as much as you can, although it's very difficult to tease out what's a mood disorder versus what's the borderline personality disorder, and just take the long view, because it takes time to sort it out, and you're not going to figure it out in 1 or 2 or 6 visits even. Lots of comorbidity with panic and alcohol and substance use and eating disorders, very common. So when we think about a crisis, and this happens a lot with cluster B personality disorders, you want to assess the level of risk to their self or others, and really differentiate between long-term and immediate risk, because individuals with borderline personality disorder are going to have long-term suicidal ideation. I mean, they probably, a lot of individuals and a lot of people that I treat, they feel suicidal every day. So it's really differentiating those chronic thoughts from what's the risk right now. Is there a plan? You know, how intense are the feelings? What's our safety plan? And trying to tease that out. It helps to ask about previous episodes and strategies that they've used in the past, kind of shoring up coping skills they may have had in the past, you know, if it's calling their mom or having a friend come visit, or whatever the case may be. And working on enhancing their coping skills. So one of the things is just, again, trying to organize and shore up their focus onto the current problem, because for them that may be very difficult to do and they just feel overwhelmed. So if you can kind of break it down for them and help them focus on what's the most important thing right now. Again, maybe it's the cutting that you're doing, and the fight with your landlord, let's talk about that later, but let's just talk about the cutting, or the increase in suicidal thoughts, and put some of that other stuff to the side. And then I think regular follow-up appointments are important as well, and identifying manageable changes. So, you know, these are individuals that we might say, like, okay, so that the goal is you're going to get the extra pills out of your house that you keep thinking on overdosing on, and then have them call us when it's done, or have them bring them into the office, or agree with them before they leave that if we don't hear from them, that we will call them, and if they don't answer their phone, then we might have to call the police. So you have like a very structured plan in place to make sure that you can keep the individual safe. But really, there's not a lot of medications that are indicated or helpful, except for treating comorbidities. And at times we'll use low dose atypical antipsychotics for borderline personality disorder. But the key is treating comorbidities and then psychotherapy. And the 2 psychotherapies for borderline personality disorder that probably have the most evidence base are dialectical behavioral therapy and cognitive behavioral therapy. So when you look at some of the components, dialectical behavioral therapy, it can be hard to find. I mean, I think in Billings, we have difficulty setting people up. There are some groups in town and some therapists that specialize in this. And so I just listed for you some of the components. Compassion is really key, just this non-judgmental approach where you use a lot of empathy, really validating their experience, trying to find kind of that kernel that makes sense and just validate what their experience is, just slowly working towards change, however small, working on what their cues are that destabilize them, and removing any access to means of self-harm. Also, over time, the goal of this type of therapy is to help recognize and manage emotional intensity and instability, and just increase their distress tolerance so that it's not so destabilizing. Another aspect is looking at identifying a problem and a behavior and examining what led up to it, so that you can look at that chain and maybe break that chain further down until so that it doesn't snowball and get to a crisis point. So those are the components of the therapy. Just a little bit more about validation. Like I said before, it's just finding that wisdom or grain of truth in that person's experience and validating it. Really being interested. Sometimes it's helpful to paraphrase back to them what you're hearing them say. So, what I hear you saying is that when that person cut you off, when you were trying to cross the street, you felt unsafe and you felt like maybe you were going to get run over, just trying to mimic back to them. And then mind read is just this idea of like, so when you were in that moment, you thought you were going to die. Is that how you felt? Just trying to validate through that technique and just being as genuine as you can be, recognizing how distressing it is to have this experience. I think I talked about everything on this slide, just kind of restating the validation point. These are just some ways to think about emotional dysregulation, which is really the hallmark of borderline personality disorder. And you have some biologic factors. Some of us are naturally more impulsive, more sensitive. Some of us have a quicker stress response and a more difficult time returning to baseline. But then you add in social factors like an invalidating environment or trauma or abuse or those high ACE scores, or families where there's just a lot of expressed emotion, and reinforcement early in life for out of control emotional displays. You learn that is a way to get attention and to get your needs met. So these are just things to keep in mind, that patients are really doing the best they can, that they want to improve. I mean, I come back to these when I'm developing some compassion fatigue, which you can easily do when you're working with individuals like this. But just kind of keeping in mind that they are doing the best they can and that it's really not their fault. And then also recognizing that you, as whatever type of provider you are, need support, and asking for it and feeling safe and developing a network of people where if you mess up, you can talk to them about it, is very helpful as well. So that's the end of my presentation. Let me open it up for any questions. Oh, I see there's one question from CHP Bozeman. Can you further distinguish between obsessive compulsive disorder and obsessive compulsive personality disorder? So this is a great question. I think these names could be a little better to make it a little clear. So someone with obsessive compulsive disorder, you think about, they really have compulsive behaviors to relieve an obsessive thought. So if someone has a fear or an anxiety about contamination, you're going to see behavior in the form of excessive washing, or repeating or counting, or some of these compulsive behaviors that help relieve obsessive thoughts. They're not productive necessarily. They don't make a lot of sense. They take up a lot of time, and don't help with functioning. People with obsessive compulsive personality disorder, they have a hard time completing things because they want it all to be perfect. But typically they can be very, very functional in their lives. Their perfectionism can serve them very well. But you see the disorder in their rigidity and their interpersonal relationships. So I hope that helps kind of differentiate the two. One is pervasive in all areas of your life. You might have somebody with obsessive compulsive disorder who spends, 2 hours in the morning washing their hands and checking before they leave the house. But in other areas of your life, you don't see that rigidity or the perfectionism or the inability to get things done. So that's kind of the difference between the two. What else? Any other questions or comments? I would love to know of your experiences. Annette, go ahead.
Some quick question. This is Christina here with Annette. So sometimes there's so much comorbidity, it can be confusing. And with borderline, I've seen some clients who I'm trying to decipher, are they borderline or schizoaffective, because they're having some psychosis. So in working with some of your borderline clients, have you seen some psychosis or some really just kind of issues with, I don't know, just very outward, like reality testing way off, very disorganized? I didn't know if with the severity of the borderline, if that's possible, or if we're looking at something totally different.
No, I think that that's a really good question, and absolutely, I do see some, like you said, the reality testing is so off that it can be hard to sort out. Is this a psychosis, of schizoaffective disorder, or is this a personality disorder? I think when you look at sort of relationships, when you look at interaction style over time, that can help sort this out some. Again, somebody may not be in a lot of mood or emotional distress, but still have psychosis in schizoaffective disorder. But it's different too, because the psychosis isn't going to be the prominent complaint or concern. It's really going to be this fear of abandonment or emotional dysregulation. And then out of that, you're going to see some distortions in reality. But, when you're trying to sort it out, is it appropriate to use an antipsychotic to try to see if you can shore that up? Absolutely. Absolutely. What else?
Thank you. That was very, very helpful. I appreciate it.
Oh, sure. Absolutely. What other questions do you have, or what other experiences can you share in your own practices about how you're managing some of these patients?
I have a question. Is that
Sure.
all right? Can you?
Yep.
I've actually studied this quite a bit, and I cannot distinguish, even in your presentation, a lot of the differential diagnoses within personality disorders are other personality disorders. And I really don't know how to sort them one from the other. They really seem to overlap a lot. And it unfortunately, in my mind, becomes a kind of a big muddled jumble of, okay, they've got a personality disorder. So I don't know how to better distinguish them.
I think that is, I'm really glad that you brought that up, because even as I was preparing this talk, I debated on going through the clusters and the different criteria, because I think that the DSM is very useful for certain things and less useful for other things. I think when we're looking at, mood disorders, it can be very helpful to try to differentiate unipolar versus bipolar depression. But when you're looking at personality disorders, I think it's the area that's least helpful. I think it's helpful to understand the different maladaptive ways that impact an individual's functioning, and certainly are going to impact their ability to interact with you and for you to deliver care. Is it important to differentiate between schizoid and schizotypal personality disorder, or do people even neatly fit into those boxes? Not very much. Not very much. I think that my experience, and I would love it if anyone disagrees to speak up or has a different experience, but I, like you, often kind of know it when I see it. I know it when I feel it in my gut. I know that it's impacting my relationship with the person or my ability to be effective. But honing down on exactly which box to put somebody in isn't always effective, isn't always easy for me to do. And I think that's just because these categories are less helpful than I think that they could be. And I don't know that we really need to do that, except for to, again, recognize that someone has a personality disorder. They have a pervasive way of being that impacts their functioning. And, you know, maybe you think about it in terms of the clusters. Maybe they're more odd, or maybe they're more emotionally dysregulated. But keeping that in mind and documenting that there's a personality disorder is helpful. And then the rest really unfolds as you get to know someone over the long term. Do you agree with that, or what do you think?
I do agree with that. It's still, you offer some suggestions about, like, not exactly treatment, but how to cope as a provider, as a caregiver, with someone with this kind of personality disorder versus that one. And, you know, when there are some distinctions in the treatment, that's when it would be nice to be able to sort them one from the other. I'm trying to think of the one that was most distinctive. You said, I think for narcissistic personality disorder, you said something that was quite different in the way they, and I don't have the slides in front of me, but you said something quite different about from many of the other ways of caring for a patient.
Histrionic?
I thought it was narcissistic. I don't know. That's what happened.
We're looking back. No, I think it's an important point. So we're looking back to see which one you're referring to.
Was it the dependent personality disorder, where multiple sources, kind of extending out your resources versus one provider?
Yeah.
For example, that was very distinct from many of the others, where we often said stay with one provider and maintain that long-term relationship, as an example. So the others, though, aren't so clear.
Yes, and so within, I think it's a bit of a judgment call, but I think like with someone with dependent personality disorder, you're going to really have that sense of the extreme neediness of that individual and inability to really kind of function on their own. And you're also gonna learn from your experience. If if you're like, I'm gonna stick with you, but then you realize how exhausting it is and how really it's not getting the need met, then you shift strategy. With any of these, you shift strategy, right? But I mean, certainly someone who is borderline is going to look very different from somebody who is more on the, like schizoid personality disorder, no social emotion at all. I mean, on one extreme, you have somebody who's extremely unstable in their emotions, and in one person, they seem almost void of any emotion. So there are differences. It's not like they're all just sort of the same, but I think it's just helpful to think about the clusters, if that helps. I don't know if I explained that any better. Does anybody in the on the call or on video have any help for us in addressing that?
Yeah.
One possible approach is, as as was kind of hinted to, is like follow your gut. Like, does this individual feel like someone who needs the one-on-one, who like paranoid, needs the one-on-one, is going to be very needs a strong relationship, or is it somebody who feels like they need support from numerous people, like further their sense of self-validation, or to assuage any concerns about potential capability of a given provider, and then it's a learning process, and then follow your gut, and if it works out, cool. If not, adjust accordingly.
Yes, I would agree with that. Anyone else have any thoughts that can kind of help us clarify? I think that the idea of trusting your gut, figuring it out over the long term, figuring out what works is it's a long-term process. These are long-term relationships, diagnoses that aren't made quickly. And again, I don't know that it's all that important to nail down the exact personality disorder, especially if it doesn't quite fit. But I think it's important as you get to know people to just think about how these things are impacting their ability to cope. Any other questions or comments about the presentation?
Hi, this is Dee at Bullhook. And question as far as, to me, in my vagueness, on the medical side of things, sort of is, well, this feels like a personality disorder patient because my heart sinks when I see them on my schedule. You know what I mean? And you know that's never going to fit in the visit time allotted. Is there your recommendations or on including like LCPCs or other counselors? We don't really have a psychologist available to us, both in helping sort out diagnoses maybe over multiple visits with them, or then also dealing with the, like, okay, I recognize it. How strongly do I push for a relationship with a therapist if they have financial access to that?
So I think if you can engage the patient in what they want to have happen and what their goals are, and present therapy as a resource to help them meet whatever their goals are, I think it's going to be more effective. Again, therapy is one of the primary treatments, especially for borderline personality disorder. So having therapy is going to be really one of the keys to them being more effective. And so, yes, if you have the resource for an LCPC or another therapist, absolutely engaging them in that is helpful. And then I think just recognizing in yourself that feeling, right, that you have, this happens to all of us, that you feel like, oh, you see the name on your schedule and you just go, oh. And just to recognize that's okay, right? And try to do what you always do with everyone. And not overcompensate for that feeling, but not, cut the visit short or do something different than you would. I think whenever we find ourselves doing something different for somebody that we don't normally do, it's sort of a red flag. If all of a sudden you're driving to church on Sunday and it's, that person is in your back seat because they needed a ride, then you got to go, well, okay, maybe, and it's amazing what can happen when you're not sort of aware of your boundaries. But, and I think that's why we sort of push back, because it feels, the need is so great, And so I just think, yeah, you just got to do the best you can and be aware of that. Do you have any other advice for that or comments? No. So, but I'm right there with you. Right there with you.
Thanks.
Any other comments from CHP Bozeman? You had said you had done this a lot and done a lot of maybe reading or having a lot of experience with this. I'm curious if you have any other thoughts.
I'm sorry if I probably overstated that. Not nearly as much experience as you've had, but I worked in a mental health unit. I'm a nurse, so not a doctor or a provider, counselor, but I've seen a lot of personality disorders, and we're trying to think of how to best care for someone with a personality disorder. And you did just now distinguish the different types, and you kind of had some ideas for how to best care for even a cluster or and I don't think that, I think it's just really hard. I think I'm conveying something that's been said in our group here, that it's just hard. I am interested to hear if the pharmacist has any ideas about, at least for the cluster that's got, anxiety, precise, we've suggested that medicines are only going to work for the comorbid clinical things and not so much for personality disorders. But and as much as anxiety is part of that big cluster, I have to think that some of those medicines could work for personality disorders too.
Yeah, absolutely. I think just to reiterate, obviously we want to treat the comorbid mental health condition that they have, but if their primary symptom that they're experiencing is anxiety, we can definitely consider trying something like an antidepressant or something kind of as needed for their anxiety. I know that you were talking about a lot of them have comorbid panic disorder, so trying something for that, but I definitely agree. Unfortunately, we don't have a lot of, randomized controlled trials on personality disorders with medications. And so we can't say, yeah, absolutely, there's a medication to treat this condition. But I think as long as it's not causing harm to the patient and they're not having any undue side effects, I think it's worth a try.
What about borderline personality disorder? Thoughts about that?
Oh my. That's a really tough one. I think in my experience working on the inpatient unit, usually those with borderline personality disorder have a med list as long as, as you can think. And so it's really hard because I think no medication works for them. Anything that you start and you try, they're going to have a side effect or it's not going to be effective from my experience. And so it's really difficult. I think I'm always a minimalist, so I'm always trying to take away medications, especially in those patient populations. And sometimes it's even beneficial to, admit them to the unit and try to reduce the medications and see how they do, kind of as a, clean slate, starting over, seeing if we can kind of really determine what are the symptoms that they're experiencing. I don't know if you have any other thoughts about that, but.
No, I think the polypharmacy is a really important piece, and it happens a lot. So I like that idea of simplifying and pulling back, because I think what happens is there's so much distress that we end up layering medication, and then pretty soon you look and you're like, oh my goodness. But then I think also the patient oftentimes can get really attached to that long med list, and it can be difficult to pull things off. But
well, and I know a lot of the providers, it's hard because a lot of these patients are coming in and they're requesting a medication, whether their friend or family member is on it or they saw it on TV. And, I think it puts the provider in a dilemma of what do? Do you prescribe that medication to kind of satisfy the patient's request or not? And, that's a difficult situation. So.
Yeah, I think we just do the best we can and try to use our clinical judgment and, learn as we go. But I mean, the hopeful thing, I feel like I need to say something hopeful about personality disorders, is that people tend to get better over time. As they age, a lot of this mellows out. People tend to be less impulsive as they get older. And so you'll see, antisocial and borderline personality folks really getting better. There's less drama as people age. And I really have seen people who are motivated and have good treatment get better. I've seen people with borderline personality disorder drastically reduce the number of hospitalizations, drastically reduce self-harm behavior, and just have an ability to function in society better. And I think it's the long view, but that's my hopeful statement about personality disorders is things tend to improve over time.
Mm-hmm.
Does anybody have a case that of anyone with a personality disorder or a difficult clinical situation that they want to discuss?
So this is Christina again. We have a couple of really difficult cases. One we were just discussing is a client who comes in regularly. She had Lyme disease when she was younger, and she brings in her feces, digging in her food. She's saying that she's got bugs in her bowel movements, and she's got worms, and she's pointing them out. Very, 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 very emotional, very dysregulated, very attention-seeking. Everything's wrong with her. She doesn't believe anybody's there helping her. She wants, like, after you give her attention, she'll call and leave message after message. She'll show up for appointments the next day. She's in a relationship, but she's been with him, and supposedly there was some abuse there. Then she left and came back, and there's issues with the family. She said this last session to me, like, oh, when I was a baby, I was bit, and they had this bullseye like mark on me, so maybe I was bit by a tick then. So there's this constant thought that she's got this illness, and she's got parasites, and she wants medication, and she wants treatment. She doesn't trust anybody's statement, but she wants to work with me. She's got a very, very flat affect, blank stares when she's talking, when we're trying to, talking together. But then when she starts talking about what's going on, she gets very labile. Our emotions are huge. It's exhausting. It's really, really hard to see what we're really dealing with. A lot of trauma history, lots of loss. It's really hard to get at the core issue with her, and she's burning up all of her resources at this point. We don't really know what to do with her. We're setting clear boundaries, trying to do some psychoeducation with her, but that's kind of hard because we're trying to figure out where get our feet on the ground, see what we're dealing with. Seems like there's been times we've done some really good work, talked about, like how the brain and body connects and what could be happening. But then the next day she comes in and we're right back where we started. So she's done things like, she said she had bugs. She felt like she had bugs in her skin, so she sprayed herself with Raid. She's taken a lot of over-the-counter medication. She's very, I think she's kind of a threat to herself because her reality testing is so far off that she'll like spray herself with a chemical. So I don't know. This is one we started working with. We've had to set boundaries with her, and it's hard because it's pulls at your heartstrings. But at the same time, how do you get somebody to understand that it's not there when the tests all come back negative, but that she's really experiencing these, and give her the therapy to help her through? I mean, that's kind of what we're struggling with right now. And we were even just talking about, would she be considered somebody with a personality disorder, which we kind of are leaning there, but which one? So there's a lot. But this is what definitely, I feel like I meet her first thing in the morning and then I'm done for the day. I feel like I don't have any more capacity.
All your energy.
But,
Yeah. Oh my goodness. Okay. How old is she?
She's in her late 40s, I think. Late 40s, maybe early 50s.
Is this a new presentation for her? Like,
no,
or is she
doing this for a while?
Years?
I think so, yes, years.
Okay. Okay, well, this is a doozy, my goodness. Okay, so we've got this, just to summarize, and correct me if I miss anything. So this is a woman in her late 40s or early 50s who has it sounds like a kind of chaotic psychosocial situation and potentially an abusive relationship, who has a belief that she has something seriously medically wrong with her. And this is creating some behavior that is quite out of what you would expect, including bringing her feces in feeling like she's got bugs in her stool, bugs on her skin, spraying herself with raids, so doing some harmful things because of this intense belief. And really not able to accept that tests have come back negative. So the questions presented to the group are, how to address that the tests have been negative, and maybe looking for some diagnostic clarity. Did I get everything?
Oh, sorry, didn't mean to interrupt.
No, go ahead. So I just want to make sure, is that an adequate summary?
Yeah, that's really good. The other thing is I'm working with her clinician. She apparently has a history of bipolar, but I don't know. That's not something I've come up with. That's what